Pathology Resident at Cedars Sinai Medical Center in California. Today I'm going to present a skin case. I hope you will enjoy it. First of all, I want to say thanks to my attending, Dr. David Fishberg, who has helped me with the presentation. Let's start with the case. This is a 47-year-old African American female who presented with a subcutaneous nodule in the left axilla. She thinks she has had a nodule for a couple of years, but she isn't completely sure. When she first noticed the reason, and her lesion isn't painful and had not bled. She had no significant past medical history. Differential diagnosis proposed by her dermatologist included dermatofibroma versus epidermolysis versus other tumors. Here is the excisional biopsy. Here we can see the large cyst and multiple foci of lymphoarrogate. Adjacent to the cyst, we can see a veiny lobular lesion starting in the dermis and invading into the subcutaneous. At higher power, we can see microcystic architecture, tubular structure, smallness, and cord-like structure diffusely throughout the lesion. And the stroma is very sclerotic. We also see lymphoarrogates, and whenever we see lymphoarrogates in the skin lesions, we think about malignancy. At high power, we can appreciate the nuclear features. The cells are pretty uniform with pink cytoplasm. Some cells have vesicular nuclei and inconspicuous nuclei. They look like squamoid. If you look carefully, you can see there are myoepithelial cells here, and also apical secretion, a feature of apocrine carcinoma. There are several small foci showing mildly nuclear atypia. The cells have abundant pink cytoplasm. Nuclei are mildly pleomorphic. No vascular or perineural invasion is seen in the lesion. In summary, we have an infiltrative neoplasm in the dermis and subphyseal subcutaneous, characterized by tubular and microcystic differentiation of eosinophilic cells within a sclerotic stroma. Nuclear atypia is very focal. We came up with a differential diagnosis based on the location and morphology of the nodule. Metastatic breast ductal apocrine carcinoma. This is less likely in this patient because she had no history of breast cancer and recently had a negative skinning mammogram. Primary cutaneous apocrine carcinoma can look identical to breast ductal apocrine carcinoma, and I will talk about them shortly. For microcystic adnexal carcinoma, it's very important to differentiate this entity from benign entities such as dermoplastic trichoepithelioma and syringoma. Morphiform basal cell carcinoma also can look similar microcystic adnexal carcinoma, and sometimes it's difficult to distinguish among all of them. I will walk you through each entity one by one. The first one, primary cutaneous apocrine carcinoma. This is a malignant tumor of sweat glands with apocrine differentiation. It usually occurs in middle-aged women. The most common location is the axillar and anogenital region. It can metastasize to regional lymph nodes and physical organs. Here is an example of apocrine carcinoma. We can see the lesion in the dermis. It could be a relatively diffuse infiltration and encapsulated. It may extend into the subcutaneous tissue. The tumor can have variable patterns, including granular, papillary, solid architectures. This photo showing papillary growth pattern, and here show granular differentiation with here decapitation secretion. We also see this feature in our case. Focal epidermotropism is sometimes a feature of apocrine carcinoma. At high power, we can see the cellular features. The cells have abundant eosinophilic cytoplasm. They are large, and some have vesicular nuclei, nuclear pleomorphism, and hyperchromasia is also common. Mitosis are often present with variable necrosis. And primary cutaneous apocrine carcinoma may be indistinguishable histologically and immunohistochemically from metastatic breast ductal apocrine carcinoma. So clinical history of primary breast cancer is very important to differentiate between them. Moving on to the next entity, microcystic adnexal carcinoma, or MAC or MAC. This entity can occur at any age. The incidence is the same between male and female. The most common location is around the eyes and nose. The tumor is indolent, but it can be locally aggressive. The recurrence rate is about 40 to 60%. Clinically, we see here a firm yellowish black with deceptive borders and a centrodale at the angle of the mouth. It also can present at a nodule here on the lower eyelid near the inner canthus, and the lesion usually causes pain, burning, and paresthesias. Here is an example of microcystic adnexal carcinoma. This is a low-grade malignant wet duct tumor. There are two subtypes, biphasic and monophasic. The one I have it here is the biphasic variant. The location is located in the dermis and invades into the superficial subcutaneous. It's similar to our case. It's hard. It can be hard to appreciate at low power the biphasic component, follicular and tubular differentiation. At higher power, the follicular formation can be seen well here, like here. Here we can see follicular horn cysts or keratocyst or cyst with pilar keratinization. And this one look a little bit like tadpole. And whenever you see structure like this, we think about syringoma as well. And syringoma is a common differential diagnosis of MAC. Here we also can see small nests or course of squamous cells with minimal cytologic atypia, and the sclerotic is very pink. The features are also seen in our case. And the ductal for tubular differentiation can be more difficult to find sometimes. It usually shows up at the deep level like here, and that's why it can be difficult to diagnose when we only have a shade biopsy. Immunostain like EMA or CEA can help to highlight tubular differentiation. Look at that carefully. We also can see the myoepithelial cell. So for MAC, myoepithelial cells are preserved. In the opposite, breast carcinoma and apocrine carcinoma, we don't see the myoepithelial cells. At the base of the lesion, it usually shows infiltrative islands of basaloid cells. It looks similar to morpheoform BCC here. Perineural invasion is common in MAC, but we do not need this feature to diagnose MAC. If we do not see PNI, that doesn't mean it's not present. Usually when we examine the deeper levels, we will see it. We also can use S100 to highlight the nerves. But keep it in mind that S100 also stains acrine structures. Here is an example of monophasic variant of MAC with ductal differentiation only. No follicular component is seen here. Another name for the monophasic variant is sclerosing sweat duct carcinoma. The next entity is morphiform basal cell carcinoma. This tumor usually occurs in the elderly and is more common in males than females. The most common location is the head and neck. This subtype is more aggressive than the conventional BCC. Clinically, morphiform BCC typically appear as a scar-like lesion. Sometimes it can resemble morphea. Morphiform BCC, a low-grade malignancy of basaloid appearing keratinocytes and may contain follicular differentiation, especially for the superficial biopsy. It can easily be mistaken for desmoplastic trichoepithelioma. Here we can see small cores or strains or nests of basaloid cells showing only limited peripheral palisading. The stroma is dense and sclerotic. Sometimes we can see perineural invasion in the morphiform BCC as well. And morphiform BCC can look identical to desmoplastic trichoepithelioma and MAC. So searching for the residual area of classic or traditional BCC can help distinguish morphiform BCC from these entities. Next entity, we have desmoplastic trichoepithelioma or DTE. This usually occurs in young adults and is more common in females. The most common location is the face. DTE is a benign, slow-growing tumor. Clinically, DTE appears as a yellowish, round, crater-formed papule. Here is an example of DTE, a piloneoplasm, a basaloid proliferation containing a mixture of primitive follicular structures and mature infundibulocystic keratinizing areas with a densely fibrotic stroma, and DTE has no tubular differentiation. So here, low power, we can see the tumor is well circumscribed, and like I can easily draw a line around the tumor. Higher power, we can see keratosis and epithelial strain embedded in a dense fibrotic stroma. And this feature also can seen in MAC. Focal calcification is very common in DTE but rarely seen in MAC. And here the keratin cyst. At the base of DTE, we can see like narrow strains or small nests of small basaloid cells in the dense collagenous stroma. It looks like morphiform BCC. But keep in mind, DTE usually occurs in young patients and morphiform BCC is found in the elderly. And if the distinction cannot be made morphology only, immunostain can be helpful. Like here, CD34 will be positive in the stroma of DTE, but negative in the stroma of morphiform BCC. Another useful marker is BCL2. It will be diffusely positive in basaloid islands throughout BCC, but only positive in periphery of DT. CK20 can be helpful too. This is a Merkel cell marker and is commonly found in DT but is negative in BCC. The last entity is syringoma. This is the most common tumor of the sweat gland. It can occur from puberty to old age and is more common in females. The most location is periorbital and genital area. This is a benign tumor with excellent prognosis. So clinically, we can see typical periorbital distribution of these small papules. In severe cases, there can be extensive involvement of the cheek. And microscopically, syringoma is a benign apocrine ductal differentiation in the superficial dermis. It never goes into the subcutaneous. And the lesion is asymmetric and well demarcated. High power, we can see epithelial strains and small cysts in a dense sclerotic fibrous stroma. Here is the tadpole-like structure. We can see in syringoma, MAC, DT, or morphiform BCC. So this table summarizes the four entities that I just talked about. They can look very similar and they share many features. They all can have small nested cord-like tadpole appearance and sclerotic stroma. The diagnosis can usually be made by H&E. Rarely, immunostain can be used for challenging cases. Microcystic adnexal carcinoma can have many of the features listed in the table, but the combination of lymphoid aggregates and peripheral invasion is quite specific. Morphiform BCC can resemble the other entities in some areas, but you usually see the classic, more recognizable BCCs everywhere in the lesion. And for desmoplastic trichoepithelioma, we don't see tubular differentiation, and we usually see calcification, and calcification are rarely seen in other entities. Syringoma is specific that it represents as multiple small well-defined lesions, and syringoma usually do not have horn cysts or calcifications. These entities are very easy to misdiagnose when we have a superficial biopsy and cannot see the base of the lesion. And finally, apocrine carcinoma or breast carcinoma, which I did not include in the table. They are ugly looking tumor with cytologic atypia, mitosis, and sometimes necrosis. They are higher grade tumor compared to the rest. And back to the case, the tumor is the uninfiltrative neoplasm characterized by tubular and follicular differentiation of eosinophilic epithelial cells in a sclerotic stroma. Cytologic atypia is focal, no lymphovascular neural invasion is seen. Scattered lymphoid aggregates are present. There are three differential diagnoses: microcystic adnexal carcinoma, metastatic breast carcinoma, and apocrine carcinoma. By morphology, it looks the most like MAC or MAC. Even though the patient had no history of breast cancer and the morphology doesn't quite match breast carcinoma with apocrine feature or primary cutaneous apocrine carcinoma, there was still some concern for them due to the location in the axilla. So we order a dual immunostain P63 and SMMA. Here we can see myothelial cells are preserved. So we can rule out breast carcinoma and apocrine carcinoma. And the case was side out at low-grade adnexal carcinoma. The location and apocrine differentiation certainly raised the possibility of apocrine carcinoma, but purely morphology most resemble MAC because of blank cytoplasm and growth pattern of microcystic. Here are my references. Thank you so much for listening to me. I hope it was helpful.